Okay. Today I welcome our bright and very important speakers. We have two speakers, one Dr. Burns, Blackthol, and Miss Ishara Shutu. The first speaker, he's a senior vice president, specialized in precision medicine at Arsensia, where he catalyzes the adoption and implementation of precision medicine across the health systems, providers, payers, and employers, which is very important. He will talk about that. Most recently, he served as the founding executive director of precision health at the CHRIST Hospital Health Network, developing a nationally recognized program for proactive, individualized care ranging from hereditary disease risk screening to a transformative pharmacogenomic program. What's important, he initiate different testing program. He will talk about that, the way how on pharmacogenomic. He received his PhD in pharmacology from University of Colorado and has held academic and faculty, and now he's faculty and leadership position at no, he was faculty and he was a leader. He got a leader position at Duke University, at also University of Rochester, and now in Cincinnati Children's Hospital and the University of Cincinnati, where he remains as adjunct professor. Dr. Blackthol is an elected fellow of numerous professional societies, holds several patents, has given more than 200 invited lectures across 6 continents, and has published nearly 100 peer-reviewed manuscripts, articles. He has received extensive honors and awards and holds several leadership roles in professional societies and boards for pharmacogenomic, precision medicine, and therapeutic discovery. Now I will leave the floor for you to present the essential of your work. Thank you so much.
Excellent. Thanks so much for the kind invitation. I'm really honored to be here. I've had the pleasure of visiting and of speaking with Ishara, who's going to speak to you after this as well. So today the ask of me, is that showing up for everybody? I should ask that.
Yes, it's okay. We can see it.
Okay, perfect. So my brief ask today for about the next 20 to 25 minutes is to talk to you about implementing pharmacogenomics. So I'm taking it for granted that everyone here understands at least a little bit of it because you belong to an organization with the title of pharmacogenomics. But just really want to dive into why we do it and what it's like. So the quick audience question, you don't have to actually answer unless you feel like it, but the audience question, what are the top 3 leading causes of death in the United States? Sorry to be US centric, that's where we have the data from. And it turns out that number 1 is cardiovascular disease, number 2 is cancer, and we recently crossed the threshold that number 3 is adverse drug events. So it's quite sobering to understand that our intent to treat people is actually a leading cause of death. In the United States, 60% of doctors' visits result in a new prescription. So people are taking a lot of medications. You may be aware of a study that was done called the Kentucky Retired Teachers Service, where retired teachers, average age 72, were taking an average of 13 medications per day, prescription medications per day. So let's dive into this a little bit more. There's a publication in 2018 that suggested that we just talked about that non-optimized medication where, retired grandma or grandpa who was a teacher is taking an average of 13 prescription medications a day. Some of those are probably intended to offset the adverse effects of others that they're taking, and we'll call this non-optimized medication. that cost the healthcare system in the United States in 2018, when this was published, more than double what it costs to care for any other major disease. So at the bottom of the slide here, you'll see on the right that there are over 55 million patients in the United States who are currently taking 5 or more medications per day. This costs our healthcare system more than any of the major diseases or the medications themselves. We currently lose an average of almost 5 737 airliners per day of people to adverse drug events. So greater than every 2 minutes now. And you're likely aware that in several global studies, it's been shown that greater than 99% of people have a variant in at least one gene that would impact a medication that they may take. And that in a couple of recent studies, it's been shown that 79% of patients have at least 3 pharmacogenomic variants. So my personal dream is that everyone has a pharmacogenomic test that they get very early in life to inform their medications. But we'll talk about some other implementation strategies. So why would we implement with pharmacists? That's the title of my talk, and why do it in primary care? And we'll talk more about details on this, but just to dive in, precision medicine is a real shift of healthcare away from reactive to proactive healthcare. Primary care is where a vast majority of proactive care and screening referrals are intended to be initiated. Mammograms, colonoscopies, all these other things. And we'll talk about details of that at the end of the presentation. In my personal view, pharmacists can function at the nexus, the center of the care team to optimize medications across specialties. So for those of you who have tried doing pharmacogenomics, if a broad panel test is done, it turns out that most of the results that come back might not be within the purview of the physician who ordered the test. So maybe the cardiologist ordered a test, but the impacted medications are behavioral health or oncology or maybe pre-surgical. So pharmacists, in my view, are a great way to function at the nexus of the care team to optimize meds across all of them. And just in transparency, a residency trained pharmacist has about 5 times the hours of training of medication management that a physician generally receives. So moving on, this is a great study that came out of Massachusetts. So in 1991, there was a study at Harvard where they looked at what happens during an average inpatient hospital stay. And this was the first follow-up since then. They took randomly selected charts across 11 hospitals in the state of Massachusetts and asked what happens during a hospital stay. So of the 3,000 charts they randomly chose, 2,809 were complete enough to do the analysis. And the first piece of data is very sobering. 23.6, so let's say almost a quarter of patients during an average 5-day hospital stay have a reportable adverse event. So first of all, I find that quite sobering that a quarter of patients who enter a hospital are going to have an adverse event during their 5-day hospital stay. But the piece that is big for us is that the overwhelming majority of those adverse events were adverse drug events. So nearly 40% of all reported adverse events were adverse drug events. So this suggests that we have an opportunity to really optimize the way that we do medication management. And I would submit that pharmacogenomics is an outstanding way to help optimize that. In a subsequent study, this is called the PREPARE trial out of Europe. Many of you are likely aware of this. Just a quick summary. They provided not a really broad pharmacogenetic panel, but 12 gene with reasonable coverage of the variants. And in the course of 12 weeks, and this was done in 7,000 patients across 7 countries, they offered this pharmacogenomic test, and basically the patient then became their self-advocate to go to their physicians and optimize their medications. And in just 12 weeks, they found a reduction of nearly 30% of adverse drug events. So I have spent a lot of time in healthcare systems trying to implement programs of precision medicine and pharmacogenomics. And this is kind of what I would give as my very brief overview of what I think a PGX program can look like. So sometimes you'll start by crawl and then go to walk and run. Crawl might be you have one physician ordering a test and hoping to optimize. But if you're thinking about a program, this is what I would submit as what a program looks like. You need to have some way to identify the individuals who are at risk for these potential drug-gene interactions. It may be a printed list of the drugs that are impacted by pharmacogenomics. It could be a robust clinical decision support tool. But you have to do something to identify who's at risk, review their assessment, select the individuals to be tested. And once you do the testing, someone needs to take responsibility to personalize the prescribing based on these PGX results and insights. And I would also say it's really important to look at drug-drug as well as drug-gene interactions. And then ultimately, you need to optimize the prescribing. Someone, again, I love the idea of a pharmacist, but someone needs to take responsibility for optimizing the medications to mitigate the risk of adverse drug events. And then at the bottom, there's that kind of beneficial cycle of ongoing medication optimization. And we'll talk about some results that we have of a study of why that is so important. So for identifying risk, let's talk about that first part of the program. If we know the medications a patient is taking, we know the genes that are published and known to impact those medications, the genes and the variants within those genes, and we know the prevalence of those variants in the population, we can actually do a prediction. We'll call this our pharmacogenomic interaction probability score. So if we get the list of a patient's medications, we know the genes that impact them, and we know the prevalence of variants in those genes. And this is a really important part in Africa, so that we start learning more and more about the type of variants that we see. We can predict the likelihood that we will change a med if we do a pharmacogenomic test that covers all of those genes. We have published on this. We have validated it in 36,000 patients retrospectively. We've done a lot of proactive work with this as well. And here I'm going to tell you about a study that we did where we worked with a major US payer, and we asked retrospectively over the course of 1 year, what predicts an emergency room or hospitalization visit? And so the x-axis here on the bottom is the importance of the feature listed above in each of the bars on predicting that ER visit or hospitalization. So at the bottom here, you see that age is the #1 predictor. And then next above that is number of medications that a patient is taking, is the #2 predictor of an ER visit or hospitalization. Above that, you see a whole lot of insurance claims. So we'll kind of pass over those. Those are more a financial impact. Then you have one disease toward the middle called chronic lung disease, which is a 1 year, 50% mortality rate. But above that, you see that PIP, that pharmacogenomic interaction probability score. If that is over 25%, if we predict that doing pharmacogenomic testing has at least a 25% likelihood that we will change a medication or a dose, that score predicted an ER visit or a hospitalization better than high blood pressure, diabetes, high cholesterol, kidney failure, heart failure, almost any disease. So for me, pharmacogenomic implementation is the lowest hanging fruit in optimizing medication today and in optimizing care of patients today. So we have a tool that can embed right within the medical record, or it can be used as a standalone. It's part of our family of companies. It's called Uscript. And this is what it looks like embedded in a medical record. And I find it very powerful because within the medical record, it pulls in on the left-hand side, you'll see the entire medication list of the patient. In the middle, there's a dashboard. It tells you whether or not CPIC guidelines recommend testing for pharmacogenomics. And on the right at the top, it also gives you that pharmacogenomic interaction probability score. So in this patient, 68% likelihood that we'll change a med if we were to do PGX. In the middle of the screen, there's a dashboard. And this is even before pharmacogenomic testing, this identifies drug-drug, drug-gene, and drug-gene-drug interactions. So here is a simple one that most pharmacists would know, that this patient is taking a drug called ondansetron, which interacts with both citalopram and azithromycin, or a Z-Pak. On the right, you'll see that it highlights, we have over 19,000 publications curated here, and it highlights that these both interact with ondansetron to increase the risk of torsade de pointes. So if you're treating a patient, particularly one who has likelihood of cardiac arrhythmias, probably don't want to combine these medications. I don't have it highlighted here, but there's an alternates tab, and it will take all the information that the patient that you have on this patient and tell you what medications would be a better choice. And so you can optimize the medications with this tool. After you do pharmacogenomic testing, then it will also help you optimize the medications a patient is taking. So this is I think, a really powerful tool to help further implement pharmacogenomic testing and make it maybe a little bit easier for a pharmacist. I still think a pharmacist is the best one to use this tool, but it actually relies on data instead of you hopefully remembering what you learned in a class. So moving on from this, we'll get to the implementation phase. And I'm not saying that everyone will be able to do this, but when I was in a health system, I had 11 pharmacogenomic certified pharmacists within our health system. Some of them are still there. To my knowledge, this is the largest contingency of PGX pharmacists in a health system that's ever been assembled. So we had 7 primary care pharmacists. They were embedded in the primary care office. They covered 35 offices, so 1 office a week. And they used the tools that I've shown you to identify the patients who should be tested, test them, and then implement the pharmacogenomic guided changes and the drug-drug interaction changes across the entire care team. So they would communicate with the cardiologist, the oncologist, behavioral health, and the primary care physician all at once to optimize medications. And then we had 3 specialty pharmacists, and I'll tell you a quick story maybe just about one of them, I believe. I won't show you the data, but so we had one in oncology who saw every newly diagnosed oncology patient. They're going to take a lot of medications, and so we offer pharmacogenomics to every oncology patient. Cardiology, we had someone for heart failure, transplant, cardiomyopathy, and ventricular assist devices. And then this gentleman saw every patient before an elective total hip or knee replacement. And what he was able to do in this population was to reduce unanticipated revisits by 40 to 70% in the first 30 days because he would do pharmacogenomics and optimize medications pre-surgically, and then also wrote the discharge medications at the time of discharge. This is a really exciting outcome. So I think, again, that implementing with pharmacists is really powerful. And in a prospective randomized controlled trial that we had initiated, our first 500 patients in the course of 1 year had a reduction of nearly 30% of ER visits and hospitalizations. You'll hear me say often, test once, query often, and that came out of this study. This is a study we did with a group called Highmark Blue Cross Blue Shield, and we did pharmacogenomic testing in a patient population. And on the bottom left-hand corner, you'll see that we were able to reduce the cost of care per patient on average by an average of $200 per member per month. So that's $2,400 over the course of 1 year if you extrapolate that out. Over the course of 18 months, that savings dropped to $20 per member per month or less. Because in this gray arrow you see in the middle of the screen, if people didn't re-engage with the pharmacogenomic results, which they didn't in this study, unfortunately, 59% of the patients who participated were prescribed drugs with significant drug-gene interactions over the course of that 18 months. But nobody paid attention to it. So you lose the savings. Once you have this data, it's really, really important to continually revisit it, because the likelihood of patients, like in this study, in just 18 months, nearly 60% of them, nearly 2/3, wound up on another pharmacogenomic indicated medication that wasn't good for them. So I encourage you again to, as you implement, to think about how you're going to query often to ensure that the patient is continually taking care of with the results that they've had. In studies that we've published previously, we've reduced ER visits and hospitalizations by 71, 39%. This was a large study with a four-fold comparator group of controls. And in this study, in just 4 months, we reduced not only ER visits and hospitalizations, but also cost of care by $1,100. In a separate study with highly acute patients, this was with a group that was in the top 10 lowest percentile for hospital readmissions over the 30 days. And with this group, we tried to further optimize that reduction of 30-day readmissions. And with pharmacogenomics in a very acute population, these are patients that after surgery actually went home to in-home care. The pharmacist would offer pharmacogenomics, visit them in home to optimize their medications. And in this study, we reduced readmissions by 52%, ER visits by 42%. We reduced mortality quite substantially, as well as cost of care. So I would say that in lots of studies, we have shown that this improves care, reduces cost of care, and has better outcomes for patients. These are a couple of recent studies. This one, Frontiers in Pharmacology in 2024, looking at a survey of studies with just 7 gene drug pairs. They found a lifetime savings of over 51,000 euros and a reduction in mortality by over 10%. In panel testing, this was a study published by my good friend Jeff Shaman, and they found that if they went to an employer and offered pharmacogenomic testing for an employee population, they found that you would reduce cost of care as well as ER visits and hospitalizations. So I think that implementation of pharmacogenomics is our lowest hanging fruit in optimizing our clinical care today. And I'm going to ask, well, you know what? I may not have shared with sound, so I'm going to reshare to include sound. Do I need to do that? Share sound, here we go. All right, and this is my friend Joanne McIntyre, and okay, sorry, I just have to enter my password to allow this apparently. Okay, so this is Joanne McIntyre. She was a co-founder of the Advocates for Universal Testing for DPYD, the gene that processes 5-fluorouracil and capecitabine. And on Tuesday of this week, the FDA and the National Comprehensive Cancer Network finally agreed to recommend testing prior to treatment, which is a huge win. But this is Joanne's story. I'm just going to share it with you quickly. Is that coming?
My name is Joanne McIntyre, and I lost my husband to a fatal reaction to a chemotherapy drug. A type of biomarker testing called pharmacogenomics would have alerted David's doctor to the fact that he was unable to tolerate this chemotherapy. Sadly, he did not receive this testing before starting the chemotherapy that ended up killing him. In 2018, my husband was diagnosed with a rare form of bile duct cancer called cholangiocarcinoma that came out of the blue. He was 78, rarely got sick, so to be diagnosed with such a rare form of cancer was a shock. David underwent a risky and very complicated surgery known as a Whipple surgery, which basically replumbs your internal organs. He survived it and was declared cancer-free, which is as good as it gets. His radiation oncologist said, "David, you are cancer-free. Go home and enjoy your life." Our next meeting was with his medical oncologist, who had a different take. He said, "We're going to do adjuvant chemotherapy using capecitabine for years." David started on the chemo, but within 6 days, he was having terrible side effects. Mouth blisters, vomiting, body rash, and diarrhea. After several days, David was so dehydrated that we took him to the emergency department. His white blood cell count was about as low as you could go, and he was admitted. Eventually, an oncologist making rounds recognized his symptoms as a severe toxic reaction. The data show that up to 1,300 people die in the United States every year from this type of chemotherapy because of a genetic enzyme deficiency. And these deaths can be prevented with a simple biomarker test. Unfortunately, insurance doesn't always cover these types of tests, and many doctors are not ordering them. David lived a good life. He was an exceptionally kind and generous human being. Our whole family has suffered a terrible loss of a husband, a father, a grandfather. It was a loss that didn't have to be, and a loss that should never have happened. After David died, I committed to doing whatever I could to save at least one life. I'm a founding member of Advocates for Universal DPD-DPYD Testing, a group working on behalf of patients prescribed the chemo medications that can cause this preventable fatal reaction. Aligning insurance coverage of biomarker testing with the latest evidence would help address one big barrier to more patients getting this testing. One unnecessary death is too many. 1,300 a year is an outrage.
All right, so I like to share that story. There's lots of stories that we can share. Sometimes they're big things like preventing death. Sometimes I've actually helped over 3 cycles introduce legislation, proposed legislation in the United States to cover pharmacogenomic testing in pharmacists. And one of my very good friends actually wound up being our congressional testimony. And her story was different. She literally had only taken one medication. It was for reflux, which she had, which was terrible. And she had seen 3 physicians, gotten scoped 4 times, tried 6 different medications as standard doses, had no relief of symptoms, randomized to our clinical trial. And then we found that she was an ultra rapid metabolizer. We got her on the right medication, and she then had no symptoms. So if you think of the cost of care and the lifestyle impact, sometimes it's the big things like preventing death, but sometimes it's the small things. All right. This is a study we did where we looked at what type of panel should you use when you do pharmacogenomic testing. So we took 89,000 patients randomly selected out of our primary care population, and we asked, we just did that pharmacogenomic interaction probability score calculation and found that 61,000 out of 89,000 patients had a pharmacogenomic interaction probability score greater than 25%, which, as I showed you earlier, predicts an ER visit or hospitalization better than most diseases. And we asked what would happen if you did different type of testing. So right now the NIH is running what's called the IGNITE trial, and this is looking at 2 genes, CYP2D6 and 2C19, and informing on behavioral health and pain medications only. If you were to do this study, this gene panel, you'd only find 19% of the drug-gene interactions. There are disease-specific panels out there. So let's take a behavioral health disease-specific panel. This actually looks at behavioral health and pain medications across 14 genes. But even using that, you would only find 23% of the drug-gene interactions in these 61,000 patients, who, as I mentioned, I forgot to mention below, we're taking an average of almost 8 meds per patient and nearly 2 PGX indicated meds per patient. If you do broader and broader panels, you will find more and more drug-gene interactions. So my encouragement to everyone is to do the broadest possible testing panel so that you can inform on the broadest possible medications. The first author on this study is actually Eleni Bofilatos, who lives in Pretoria, which is outstanding. So just a couple more things and then I'll wrap up. There are a lot of disparities in adverse drug events, and this is why I'm really excited to be participating in some studies in Africa. one of the biggest problems we've had in clinical trials is that over 98% of them have been done in old white men, which is a real problem. So we lack representation of women and minorities in studies. In a couple of studies, it's been published that the Black patients have a much higher odds ratio of an adverse drug event compared to their Caucasian counterparts. And again, having not been included in the clinical trials renders us unable to prevent those adverse events because they haven't been studied. So I'm really excited about what's happening to really try to define ethnic disparities in pharmacogenomics so that we can optimize those. What I think is also underappreciated is that because there's also a lack of representation of women in clinical trials, women have twice the rate of adverse drug events in 29 of 30 categories. So we have a long way to go to really optimize that we care for patients, even using pharmacogenomics. So again, very excited for the work that will be done to try to identify the diversity of pharmacogenomic variants and the medications they impact. So almost ready to wrap up here. This is a study that was just published from the UK, which I really liked. They did a survey analysis and had 2,700 patients who responded. And they asked first, have you experienced either no benefit or a side effect from medication? So 59% said yes. 89% said that they understand there is variability in the way patients respond. Most of them did not yet know about pharmacogenomics, but about 52% said they think DNA might be able to help predict that. During the survey, they then educated people on what pharmacogenomics was. 89% of them, once they understood it, said they would do a pharmacogenomic test. So people want this once they understand it. Part of our mission is to educate them, and then the rest of our mission is to make sure that we implement it correctly so that we can optimize their care. And then this is kind of, I call this my shock value slide. So we did a calculation and we asked, what are the kind of things, we'll just go US focused for a moment. What are the kind of things recommended in the United States that nobody would say you shouldn't do? So these are things like mammograms, low-dose CT scans of lungs, and colonoscopy. So mammogram, woman over 40, lifetime cost about $1,300, prevents 2 deaths per 1,000 lives screened, with an annual death rate of 42,000. Low-dose CT for people who are 30-pack year smokers, highly recommended, saves about 3 lives per 1,000 screened, 12,250 lifetime cost. Colonoscopy, so much fun the day before, especially. And that saves about 28 lives per 1,000 screened with a lifetime cost. As I told you in the beginning, adverse drug events are the 3rd leading cause of death in this country at a 350 plus thousand deaths per year. If we were to have a pharmacist visit with a patient to optimize their medications and do pharmacogenomics and implement those changes, based on the studies that have been done so far, that would save 106,000 lives per 1,000 at a lifetime cost of $450. So for me, again, lowest hanging fruit in medicine today, I'm still not sure why we haven't made it standard of care. I hope that we can. And I'm just going to put up my email is here. If I can be helpful in any way, just in talking you through how to implement, how to crawl, walk, and then run, or anything else, I would really love to connect with you. I'm very passionate about trying to drive change in underserved communities. I lived in South America for several years trying to do the same. And if you're super interested, these are all the references for that last slide that I showed you. And I thank you very much for your time. I will be happy to take questions and then turn it over to Ashara. So I'll stop here.
Thank you so much for the outstanding talks, Dr. Burns Blackthol. It was very interesting what you presented, and especially you have some data out of patient, from hospitals and what's, the ongoing studies. Actually, this is in US, but we want to see that actually everywhere, not just North America and US. It's something now pharmacogenomic, like you showed. It's the lowest, like, you know, in terms of pricing, but in terms of the effect on health and on patient till up to death, it's actually it's very, very important and very serious. Okay, now I'm looking for any question from the audience. Otherwise, I will give you just a quick question. I know you mentioned.
I have a question.
Yeah, go ahead, please.
Yeah, thank you very much. It was an excellent presentation, very clear. So my question to you is that, do you need to follow the same model for low and middle income countries? Like the details you describe is, you know, it requires resources, infrastructure, and genetic testing, which is so diverse, for example, from place to place in Africa. So what kind of models should we follow for low and middle income country, or should we replicate whatever we have here in the US or Western country?
Yeah, it's a great question. So I'll go back to my analogy of crawl, walk, run. I think crawling for a low and middle income country, there are several models of this where part of it is the education, because there's a requirement to ensure that patients understand why they're getting tested, because they might be resistant to doing it before that. So I think developing a little bit of awareness is very important. Like that UK study showed, most people didn't know what it was, but when they found out what it was, 89% of them would want to do it. So I think education is key. And then there are foundations that can help you with doing some genetic sequencing, some pharmacogenomic testing. There are even grants available, and there's some great examples in Africa of folks who have utilized these foundation funds to help drive pharmacogenomic testing. And then it comes down to the question of how you want to implement. The PREPARE study in Europe actually put it on the patient. They gave the patient a QR code that they would take to their physician to show them what meds they shouldn't take. So you can put it in the hands of the patient. There are other models where you just have one physician or a few physicians who are very passionate about this, and they can drive it in their own patient population. Academic medical centers, private foundations, there's all sorts of different ways. So I don't think that there's a one-size-fits-all answer to your question. There's a really great company started by my good friend Carlos Bustamante called Galatea Bio, which is in South America doing sequencing of the Latino population, which is also incredibly underrepresented. And they're offering return of results as well. So I think there's a lot of different models. I don't have a one-size-fits-all answer to your question, but thank you very much.
Well, thank you so much. We'll have quick question from Professor Colette Tandara before to move to the next speaker.
Yes, thank you very much for such an illuminating presentation. My question is on the level of evidence that we need before we translate. I think we've always been saying pharmacogenomics is the low-hanging fruit, but we are not seeing it being translated into the field. Do you think that we necessarily require randomized clinical trials? Vis-a-vis, if you look at the use of empirical dosing, usually most of the things don't. I mean, most of the like you showed with the colonoscopies and all, they don't work 100% of the time, but we use them. So what do you think with pharmacogenomics? Because it has always been a barrier that they want, or you are required possibly to show RCT evidence. Thank you.
I'm going to share a slide from a presentation I recently gave on this. So is it ethical to do a randomized controlled trial of pharmacogenomics? And this was almost a satire editorial that was written back in 2003. And it asked the question, there were no randomized controlled trials of parachutes to prevent injury following gravitational challenge. Right? So then the next question is, there's only two options. We either accept that common sense might be applied, or the second is that we have to do a randomized controlled trial. And therefore, we feel that the people who are blocking the implementation of pharmacogenomics would be more than happy to volunteer for the randomized controlled trial of a parachute. So, the evidence is there, and there's been a lot of resistance. Please understand that the people who lobby against this have a lot of money. There are very few pharma companies who enjoy pharmacogenomics because it means less people take their drugs. So there's a heavy lobby against it, but the implementation is difficult as well. And the vast majority of members of panels who make these decisions didn't train during an era where they learned genetics or how to implement pharmacogenomics. And so sometimes just the fear of change is an enormous problem. I think that the more lawsuits that come along, the more change will be driven. And that's where I have seen the change. I had oncologists who didn't want to do pharmacogenomics at all. Then there was a lawsuit and they kept asking, why aren't we doing pharmacogenomics? And I was like, because you said you didn't want to. So, legislation and lawsuits tend to change things. And I really hope we can get there. Thanks for the question, Colin.
And we thank Professor Colette Dandara. He's our chair. And if he wants to give a short, quick.
I know we are over time. I just want to say thank you very much for agreeing to the invitation. Beautiful talks, and it gives us a lot of thinking to do as the researchers on the continent, and also how we can work together, particularly academia and industry, in terms of realizing the dream for pharmacogenomics. Thank you.
Thank you so much, and thank you for all of you to attend these great talks and opportunities actually to see what's going on with the other partners, and especially awareness. That's Dr. Burns Blackthol, that's what he said. Education for pharmacogenomics.
Please, thank you very much for the invitation. It was really honored to be here. Please include me on invitations. I'd love to keep participating. I'm not averse to coming to Africa. I was actually just there a month and a half ago, and I'd love to come back and do what I can to help. Such a pleasure. Thank you
So much.
Thank you.
Thank you.
Thank you. Bye-bye.